This is interesting because it's a right eye, and I'm going to do a nasal injection. And you can see that I like the nasal injection sometimes for the left eye, the patient right eye, because I'm using my dominant hand, but if they don't have a large nasal bridge, I can get a really acute angle for the injection, and then I can use my left hand or finger to counter pressure without having to use a Q-tip. And you see I can go in there, but even at an acute angle, sometimes the implant will adhere a little bit, but you can see that it gives you a better opportunity to have the implant release quickly and fall inferiorly. So here we have a right eye, a pseudophakic patient. Patient had a pretty myotic pupil. You can see a little irregularity. So I'm really going to use my non-dominant hand. The patient's moving around a little bit. We're trying to get the upper lid stabilized. And if you just keep talking to the patient, there's a lot of patients are generally very nervous. They will trust the surgeon. And you can see I put that in, and I just pull it out pretty quickly sometimes, and I just wait patiently. I can have the patient look around a little bit, look up, down, and just give it time. It's not adherent to the injection site, but it may just want to stay there for a little while, and then you will slowly observe that, and here I make a small slit beam so hopefully it's a little bit better focused. Have the patient look around a little bit. I don't massage the eye. I can have them close the eye. I just let them be comfortable, relaxed. They don't feel anything with the injections, so they're not in any discomfort or pain. They've been given proparacaine. I will put a drop of a betadine in as well. I don't know if you have to do that, but I do that. And I'm just watching this. I'll let them blink. Sometimes I'll let them sit back, and then have them just put their chin back on the chin rest in about 45 seconds to a minute. I'm talking to them. Often there may be somebody in the family with them if they're older, and you can see that it just slowly finds its home, and it will slowly migrate to about the 6 o'clock position. So here's again a pseudophakic patient. You can see there's a lot of chemosis, a lot of injection in the eye from the topical medications. This is an ideal candidate for DURYSTA. So I'm talking to the patient the whole time here. I'm trying to weck cell, and this is when I discover that the weck cell is just not firm enough. It's one of my first attempts at this. So I started to use my finger, and if you don't get in right away or the patient's moving, just stand back and then go more clear corneal. So this was, I think, the second patient I ever did. At this point, I thought it was a great idea to use a staff member to hold the lid, and at that point I was trying to use weck cells soaked in proparacaine. I didn't realize that you would have no counter pressure with them. So this is essentially non-counter pressure, and you're going to have a little trouble initially just figure out where your hands are and how you want to approach the eye. So you can see I'm kind of like trying to figure out, okay, how do I want to get in here? What angle do I want to go? It's also very helpful to make sure that if your staff member keeps the forehead as far forward as possible. I went in a little deeper than I do now when I first started, and I always try to stay below the pupil, and I went down for an angle and released the bimatoprost. And you can now see that it sort of like a log starts to roll or slide like a toboggan into the inferior angle. Patient has no pain, and I can honestly tell you most of them are beyond impressed and very thankful at how painless it is. Almost all of them are terrified that you're going to put something into the eye, so I don't say I'm going to inject something in the eye. I tell them I'm going to place the medicine, and I think we're all a lot happier with that.